Great. Well, given that it's the evening, let's not stand on too much ceremony and get into it. Hi, everyone. My name is Ben Corio. I'm an acting Senior Health Promotion Program Manager at CERSH, the Centre for Excellence in Rural Sexual Health. I work in Wangaratta and I live in Yakananda in Northeast Victoria. It's my pleasure this evening to welcome you all to CERSH's Sexual Wellness Professional Development webinar for August 2024. I do want to note that we host these PD webinars monthly for most of the year, so I would really encourage you to check out our website and be on the lookout for a bi-monthly newsletter for news about future webinars, so you don't miss out on any other excellent sessions like this evening's. Before I go any further, I would like to offer, on behalf of CERSH, an acknowledgement of country. I'd like to acknowledge the Yamatang people, who are the traditional custodians of the land that I'm speaking to you from this evening. I'd also obviously acknowledge the traditional custodians of the lands which each of you are living and working on. We extend this respect to elders past and present and to all Aboriginal and Torres Strait Islander colleagues joining us today, and indeed to all of our Aboriginal patients and community members who we work with and who may well be the intended beneficiaries of the work that we're discussing this evening. It would be wonderful if you could take a moment to introduce yourself in the chat and mention where you're calling in from, or from which country and whose country you're calling in from. Would be wonderful. So it's my pleasure to introduce Dr. Haris Noor. Dr. Noor obtained his medical degree from Monash University 2012 and has worked in Bendigo and around the region since 2013. Prior to commencing his postgraduate specialist training in general practice, he worked as a paediatric doctor at Bendigo Health and Monash Health for nearly 2 years, whilst completing the Diploma in Child Health. During his training as a GP Registrar, Dr. Noor also started working in the Urgent Care Centre at Dhelkaya Health and the Emergency Department at Bendigo Health, in addition to completing the Emergency Medicine Certificate through the Australasian College for Emergency Medicine. After completing the training in general practice and gaining a fellowship with the Royal Australian College of General Practitioners in 2019, Dr. Noor continued working as a GP both in private practice and at Bendigo Community Health Services, as well as a visiting medical officer at Dhelkaya Health. Apart from enjoying the rewarding and broad aspects of medicine in general practice, Dr. Noor also maintained his special interest in child and adolescent medicine and emergency medicine. He further developed a special interest in LGBTQI health, including transgender medicine, which we'll be, I understand, talking more about this evening. Semi-regularly, Dr. Noor also does locum work as a senior medical officer to care for patients in emergency department and the inpatient ward at rural and remote hospitals around Australia. And in his spare time, if you can believe that he had any, he embraces his adventurous side, off-roading, camping, hiking, paragliding, and getting into archery. Just quickly before I hand over to Dr. Noor, a little bit of housekeeping. We should have time for questions, but if we can ask everybody to keep them till the end, either drop them in the chat as you go, as they occur to you, and I can ask them at the end, or we can pop your hand up and turn your microphone on at the end to ask those questions. I'll also note that we are recording this session, so if for any reason you'd like your question to be anonymous, please note that when you ask it in the chat. So without any further ado, Dr. Noor, over to you.
Well, thanks very much, Ben. Hello, everyone. I'm Haris, and thank you very much for such a lengthy and introduction. That was just a little bit about me, I suppose, but we'll get straight onto it. So I suppose there are a few things that I'm hoping that we can all learn today. In particular, I guess we wanted to look at how people can experience in diverse ways gender and sexuality. We'll also like to sort of cover some key health issues, including sexual health, that affect LGBTQI patients. We'll also look then into some ways we can make our practice a bit more safe and inclusive for LGBTQI patients, and also explore some specific sexual health issues affecting LGBTQI patients and how to manage them. LGBTQI LGBTQA plus is a lengthy term, and it started off fairly simple, really, with LGB, with lesbian, gay, and bisexual, and then the T was added to it because transgender people were also marginalised and needed a community to feel safe within, and then some other people that are also marginalised and don't really fit in the sort of more sort of heteronormative sort of type social structure, like people who are intersex would also join in. Queer is a term, is more of an umbrella term to refer to anyone really that is just not necessarily straight or not necessarily identifying as the same gender that they, or same sex that they're born with. Asexual people, and plus also is also, I suppose, in some ways an additional sort of umbrella term as well. We're going to go through some key concepts, and I'm hoping that I can make it clear that gender and sexuality exists on continuums. Often people think of it as on or off, black and white, binary sort of constructs, but they're actually quite, they exist on a spectrum, and they are certainly independent of each other. I'm not sure if anybody has seen the Gender Bread Person, but this is something, a resource, a fantastic free resource you can Google online. There's a website dedicated for it. It is a summary, is a visual summary of concepts around gender and sexuality as well, which is really, really great for as a teaching tool. But essentially, it covers things such as biological sex, which is also known as sex assigned at birth, and we call it SAAB for short. And your biological sex, as you know, would be determined by the chromosomes that you have upon your conception, and your chromosomes then determine the hormones that you would produce. And these will then subsequently determine your physical and sexual characteristics, such as what genitalia you have, your reproductive organs, the body shape and size, your body fat distribution, your facial hair, your body hair, and your voice pitch. And these sexual characteristics and physical characteristics are not binary, but they exist on a continuum or spectrum. And a good example of this are people who are intersex. And there are lots of different conditions that can result in an intersex situation, and as you can see in that table there. And we also even, in babies that are born with genitalia, then it's not quite male or not quite female. We call it ambiguous genitalia. And that in itself is an example of how biological sex can exist on a continuum. Gender identity, however, is your internal or your inner sense of being a man or being a woman. And it's often established early in childhood. And you'll see kids that are sort of preschool, they might start, oh, because I'm a boy or I'm a girl and things like that. So they start to have this sort of inner sense of being a female or male. However, some people obviously don't necessarily feel that they fit within the sex that they're born with. So the term cis and trans are used, and we sort of borrow that from the Latin word cis, which also we use it also in chemistry, which means on this side of, and trans meaning on the other side of. So people that are cisgender means essentially that your gender identity fits within the sex that you're born with. So someone who's born as a male also feels that they are a man. So that's an example of cis, whereas trans would be the opposite of that. And I think that this, in the top right corner here, you can see a sort of visual representation of how the inner sense of being a man or woman can exist on a spectrum as well. There are a few terms that would be worthwhile exploring quickly, or at least explaining a little bit. So we talked about cisgender and transgender. Sister girl and brother boy, these are Indigenous terms. To refer to sister girl would be someone who's born as a as a male who identifies as female, whereas a brother boy would be someone who's born as a woman, as a female, and identifies as a man. Non-binary, on the other hand, is essentially a description for people. It's a sort of umbrella description, really, for people who don't necessarily feel that they fit within the male or female sort of binary identity. So for many people, this identity can be stable. That means they feel that they don't quite feel like they're man or woman. They feel maybe they're somewhere in between, and that identity is stable over time throughout their life. Some proportion of people who identify as non-binary might have a bit more fluid identity. And so that means that maybe in some points in their life, they might feel a little bit more towards the feminine side, for example, and then maybe some months later or a year or two later, they might sort of shift a little bit more towards the more masculine side. So this sort of fluidity of their gender is almost like, just imagine that they're sliding along that scale. And then we have gender expression. So this refers to the way we present and express our gender identity. So, and this is expressed through actions, through our body language, our hand gestures, our demeanor, the way we walk, the inflections in our voice, the way we dress. And these are also invariably affected and influenced by cultural norms as well. So as an example, here in the bottom right corner, we've got a depiction of a lesbian couple. The one on the left dresses quite femininely, or presents quite femininely, whereas the one on the right presents her gender expression in a more masculine way. But neither of them are feeling that they want to be a man or anything like that. They're both quite comfortable being women, attracted to women, but they express gender differently. So we then have a few terms within this sort of concept. Androgynous, meaning someone who's not really quite clear if they're male or female in their appearance. Tomboy, and butch would be terms that we may have heard as well to describe girls who are a bit rough, maybe a bit more masculine. Sissy and effeminate might be terms to describe men who are more on the feminine side. And some of these terms may not be politically correct. And it is interesting that some of these terms have actually been reclaimed by people within the LGBTI community, so that it loses its insulting power, so to speak. And so this concept quite clearly separates your gender identity to gender expression. So the two are not the same at all. We then go to sexual attraction. So this refers to who you are sexually or romantically attracted to. And people may have, a lot of people probably would have been familiar with the Kinsey scale. On one end, you're exclusively heterosexual, and on the other hand, you're exclusively homosexual, and people generally exist somewhere in this continuum. But it is actually quite important to understand that sexual attraction is not the same as romantic attraction. So someone can be sexually attracted to a particular gender, but they're not really romantically attracted to them. So, and in actual fact, this may describe some subsets of people within the men who have sex with men group, or women who have sex with women group. So they would have sex with men, but they're not really romantically attracted to men as such, and they would still have romantic relationships with women as a result, but they might just sleep with both men and women. So in a nutshell, biological sex is what you're born with. Gender identity is what you feel on the inside. Gender expression is how you show your gender identity to the outside world. Sexual attraction is who you sleep with. Romantic attraction is who you fall in love with. I'm going to just do a quick quiz, but I'm also aware of time. So I'm just going to not do the quiz with you guys, but it is important to realize that some societies in the world actually recognize more than two genders, which again reinforces the idea that gender is a social construct. And also that being transgender is, generally speaking, not a phase. And that can be a pretty harmful misconception particularly for adolescents and kids who have expressed that they're not a boy or girl, and it's incongruent with their assigned sex at birth. I think that we're going to briefly talk about gender dysphoria and how that relates to being transgender or gender diverse. So being transgender or gender diverse is a sociological term. It's an anthropological term to refer to the fact that your gender identity doesn't match up with the sex that's assigned at birth. So there's an incongruence between the gender and the sex. Gender dysphoria is a medical term or medical diagnosis that refers to the discomfort or distress caused by that incongruence, and it must last at least 6 months. That means it is persistent. I think that if there might be some of the attendees for tonight's session who might be trans, but for the vast majority of us, you would be a cisgendered man or woman. And it is a good sort of thought exercise to imagine what happens to your body if you were actually of the opposite gender, and that's not what you want. And I think that it allows you to understand a little bit the experience of some transgender people and gender diverse people being completely distressed and completely unhappy with the fact that they're trapped in a body that they didn't ask for. Gender dysphoria is defined in DSM-5, but it is no longer recognized as a mental health condition. It's just listed there in DSM-5 simply so that we can all have an agreement on how to diagnose gender dysphoria. And again, it's emphasizing that there is that accompanying distress as a result of the gender incongruence. In general, what you tend to see is that when trans or gender diverse people go through puberty, when they start to develop secondary sexual characteristics, is when the dysphoria or the distress starts to emerge. Because as a child, and as a 3 or 4, even in primary school, perhaps early primary school, you know, you're a female body and a male body is not that different in its general shape, apart from the genitalia. And then when you start to go through puberty, you will become very different, and that gender incongruence becomes even more distressing. Just a list of the DSM-5 criteria. I'm not going to go through this, but there are different criteria for adults and children. And again, they have to meet a certain number of criteria, and the symptoms have to be lasting for more than 6 months. We're going to go through and talk about some of the key health issues that uniquely affect lesbian, gay, bisexual, transgender, gender diverse individuals. And some of you might be surprised to hear that that gender diversity has existed through history, and this is not a modern phenomenon. We've just been able to more correctly define what it is to be a transgender and what gender incongruence is, whereas people back in the days maybe don't have the language or the concepts around gender to properly express what's going on. And certainly because these people, even through history, are different from the rest of the majority of people, they do tend to be oppressed or marginalized. So they tend to keep quiet about things. So often you have no records of things. However, there was a Roman emperor that back in the 200 AD, 200s AD, Agelabalus was declared an emperor at the age of 14. Unfortunately, assassinated at the age of 18, so it was a very short tenure. He was married a few times. In actual fact, he married 5 times and divorced 5 times as well. His most stable relationship was with his male chariot driver. He was known to pluck his body hair, wore cosmetics and wigs. And he had also, on record, offered vast sums of money to any physician who could give him a vagina. If those things don't tell you that this person is transgender, I don't know what is. The statistics on lesbian, gay, and bisexual people certainly have highlighted a higher degree of psychological distress compared to their heterosexual counterparts. For example, 1 in 3 meet criteria for anxiety disorder versus 1 in 7 in heterosexual people, and 1 in 5 bisexual, homosexual adults met the criteria for affective disorder. So that could be depression, for example, or bipolar, versus 1 in 17 in heterosexual people. There is also a higher proportion of cigarette smoking, alcohol use, and illicit drug use, and we'll obviously need to pick apart why that is. But it is also interesting to know that a lot of people are actually hiding their sexuality or gender identity, and this statistics also show that 42% of people actually hide their sexuality or gender identity at social and community events that they're supposed to be part of, or feel that they belong to, and 39% hide at work, 34% hide when they're accessing services. And nearly 50% have had serious suicide thoughts versus 15% in heterosexual people. If you look at the incidence of how many people are lesbian, gay, or bisexual in Australia, the statistics would show that about 11% of people do not exclusively identify as heterosexual. Of those 11%, 6 of them are unsure. 2% are attracted to both sexes, and 3% are attracted to same sex only. So it is actually certainly more common than you think. To the impact of the stigma to the transgender and gender diverse people are even more horrific. 87% of them have experienced stigma and discrimination. There is a lifetime diagnosis incidence for anxiety at 67% and depression at 73%. So that's a significant amount of people who are transgender or gender diverse that eventually will get a diagnosis of anxiety or depression. 43% have attempted suicide, 63% have self-harmed. And nearly a third of transgender and gender diverse people have avoided medically necessary care. They've got something going on, a condition crops up, but they've avoided seeing a doctor or going to the hospital because they fear discrimination. So why do we have high rates of tobacco, alcohol, and substance use? Generally speaking, it's to do with coping obviously maladaptive, but a coping strategy nevertheless to cope with discrimination, the isolation, and the day-to-day difficulties that they experience. There's also a component in some certain groups of LGBTIQ settings where substance use can be normalized. So there's that as well. It is also worthwhile knowing that most LGBTIQ people have had some form of intimate partner and family violence in their life. And the drivers of these violence are fairly similar to those drivers of violence against women. And as we know, having intimate partner or family violence is a contributor to financial distress, food insecurity, and homelessness, which you do see probably a lot more as well within the LGBTQI community. There are some unique abuses that other members of the community do not experience, apart from LGBTQI people, and that could be in the form of corrective rape. So that's a term to describe a hate crime in which the victim is raped because of their perceived sexual orientation. So, for example, a gay man may be raped by other men for being gay, or a lesbian might be raped by someone by a man, for example, for being lesbian, and just trying to get them to straighten them out, so to speak. There are also threats of being outed, so they're constantly hyper vigilant, and understandably at high levels of stress and anxiety. They're also worried about being exiled, disowned, either by their own family members, their flesh and blood, or by their community at large. Transgender and gender diverse people unfortunately experience even more physical and non-physical violence compared to lesbian, gay, and bisexual people. And as a result, they also experience higher risk of suicidal thoughts and behaviors as well. Moving on from mental health, we talk about sexual health now. So it's not an exhaustive list, but I suppose just give you a bit of a guidance of the sort of sexual activities that people might engage in. So lesbian people would usually engage in oral sex, finger vaginal penetration, and mutual masturbation. It's less common for sex toys to be used, but if they are used, they're often used for penetrative sex. Gay people would have oral sex. They may engage in rimming as well, so oral to anal sex, essentially. Not everyone will engage in this. Anal sex, again, not everyone will engage in anal sex, and it's important to distinguish between the receptive versus the insertive partner, particularly when it comes to taking sexual history. We usually call it top and bottom. So top is the insertive partner, bottom is the receptive partner. Mutual masturbation as well, and less commonly fisting, or essentially putting entire fist into the anus. Bisexual people, so I sort of put men who have sex with men and women who have sex with women in that sort of category as well. And they certainly can have any combination of oral sex, vaginal sex, anal sex, or anything that gay and lesbian people would do as well. And transgender, again, it can be anything as well, and it depends on what anatomy they have and depends on their sexual partners. Let's look at STI patterns in lesbian women or women who have sex with women. The current evidence indicates that cisgendered lesbian and women who have sex with women have the same rate of STIs as their heterosexual counterpart, but the prevalence of certain STIs are a little bit different. So what that means is that, in other words, they're not necessarily at higher risk of STIs, but the prevalence of certain STIs are a bit different. It's worth noting that up to 90% of women who have sex with women have had or still have male sexual partners. So it's important, again, to explore properly when it comes to sexual history taking. In Women who have sex with women, the prevalence of bacterial vaginosis are significantly higher, about sort of 20 to 50% than exclusively heterosexual women. You can also get transmission between women of trichomoniasis as well. So it's often important to treat both the patient and the partners. Women-to-women transmission of chlamydia, gonorrhea, and HIV are uncommon in general. We don't really have any data on women-to-women transmission of syphilis. But again, it's based on the overall data, we don't see that lesbian or women who have sex with women at a higher risk of STIs. In comparison to gay men or men who have sex with men, there are significantly higher prevalence and incidence of almost all STIs in this population group. The number of new cases of chlamydia and gonorrhea since 2012 has certainly steadily increased, except for the sharp decline during COVID-19 pandemic, but that actually is true for essentially all STIs as well, not just chlamydia and gonorrhea. In 2022, the data showed that there are more new infections in HIV positive gay and bisexual men compared to HIV negative gay and bisexual men. So what that means is that HIV positive gay or MSM are more likely to get chlamydia or gonorrhea compared to the HIV negative counterpart. It may reflect possibly some more risky sexual behaviors, in particular not using condoms. There are increasing number of new syphilis cases as well. In 2020, there are 4.4 times more cases in men of new syphilis cases than in women nationally across Australia. And certainly happy to see that when it comes to HIV, the number of case notification have certainly decreased since 2016. And it's very likely due to the widespread use of HIV PrEP. Still, in 2021, men are still very much more likely to be diagnosed with HIV compared to women, up to 7.8 times across Australia.
Yeah.
Just an interesting graph to show you the gonorrhea notification. So just wanted to highlight essentially the top two curves. So the bottom one is the female and the top one is male. And in female, there's certainly been increasing number of cases for gonorrhea, and certainly is the case for a man as well, or male, but the increase is certainly a lot higher. We still see a lot more cases. In actual fact, the gap between, if you can see right at the start in 2013, the distance between female cases and male cases are a lot smaller than the distance in 2022 between male and female cases, if you look at it vertically. Syphilis, fairly similar trend, increasing cases in women, increasing cases in men as well, and the gap is increasing too. So again, comparing 2013, the gap between women and men, and in 2022, it's a stark difference. It's worth remembering, as you may already know, that there is a large number of syphilis cases in Aboriginal and Torres Strait Islander communities compared to non-Indigenous people. And this is a graph showing you the notification of syphilis comparing people living in major cities, regional and remote areas. Interestingly, people in the regional areas have got fewer notifications compared to people in the major cities, but people in the remote areas has certainly got the highest rate of notifications across the years since at least 2014. When it comes to HIV, I've already pre-highlighted for you the ones in pink. the data that is of most interest. You can see here, HIV notification for male is significantly higher than female or transgender. Again, it's worth remembering that transgender people may be underrepresented here because their gender identity may not match the registered sex at birth, and that has an impact on how we collect the data as well. And if you look at the age, young people, when they start to become more sexually active, sort of 20 plus, you can see cases of HIV, but it's not restricted to any particular age group. You can see people even in 50 plus are also diagnosed with HIV. So don't assume that your 70-year-old or 80-year-old man is not having sex. In Victoria, we are leading in HIV cases at 187, followed by New South Wales second. We've got to be good at something. And when it comes to risk category, male to male sex is certainly associated with higher notification cases. And if combined with injection of drugs, it is a smaller proportion. And people that are having heterosexual sex also get notification as well. So definitely not exclusive to gay men or men who have sex with men. So this is a bit of a sad graph to show you that across the years, from 2013 to 2022, the number of men that are reporting getting comprehensive STI testing in the prior to 12 months has not really increased. We wanted to get, if anything, it's actually dropped a little bit, and that's probably partly because of the COVID pandemic, but the numbers have not recovered for 2022. So, which means that we probably, at the moment, because of COVID, we are still under testing gay and bisexual men. So we do need to do better at testing them. And the comprehensive testing is defined as at least 4 of the following. So having an anal swab, throat swab, penile swab, urine, or blood test. We'll talk about other infections that can occur in gay or men who have sex with men as well. And there's certainly increased risk of hepatitis A for people who practice rimming. So that's the oral to anal contact. And just as a brief reminder that hepatitis A is transmitted through fecal oral route. Generally, you tend to see it when people are traveling to certain countries like third world countries or low socioeconomic sort of countries because of the poor sanitary conditions. So we don't really see hepatitis A a whole lot in Australia, but people who practice rimming and they might go overseas and they return, they may be at increased risk potentially. And hepatitis A, fortunately, does not cause chronic liver disease like hepatitis C or B can, but it has the potential to cause acute liver failure in some cases. And it's also impossible not to hear about monkeypox as well. And since the global cases have emerged in May 2022, it's been declared as an outbreak by WHO in August 2022. It's not necessarily a sexual transmitted infection because it is transmitted through mainly prolonged physical contact, intimate contact, essentially like the skin-to-skin contact that you have during sex, through respiratory droplets, contact with contaminated surfaces and objects. But because sex is certainly one way to easily transmit monkeypox virus, it's associated with that. There is an increased risk of monkeypox in gay, bisexual, and men who have sex with men, especially those who have traveled to an outbreak areas, have multiple sexual partners, or go to large parties or sex on premises premises venues such as the gay sauna. If you don't know what gay sauna is, it's essentially like a public bathhouse for gay people, but they don't go there to clean themselves. They go there to have sex with casual partners over there. And then we've got things like anal warts and anal cancer, which we know are caused by a human papilloma virus infection. Men who have sex with men have about 17 times the relative risk to develop anal cancer than other men. Fortunately, because of the HPV vaccination with Gardasil, we're seeing a lot lower rates of HPV infection in younger men. So hopefully, eventually, we will eliminate anal cancer, as we are hoping to eliminate cervical cancer. In trans and gender diverse people, the STI patterns are nebulous. We don't know because we don't have a whole lot of data. We're still collecting data. And so far what we have is very, very limited. I might have touched about underreporting, and that's because their gender identity might be different to what was registered as their sex at birth. However, based on international studies in low and high income countries, we found that the STI prevalence in TGD people are greater than of the general population. There is also the facet of transgender and gender diverse people already being part of other existing populations, such as trans men who have sex with men, non-binary sex workers, Indigenous brother boys, sister girls, people who inject drugs. So we think that transgender, gender diverse people, or at least some of them, may share the same risk exposures like these other population groups. So we're going to talk about how we can maybe improve our practice. So we want to break barriers. We want to create a bit of trust and safety for our patients. I think the first thing to note is really to make no assumption and make no judgment whatsoever, because LGBTQI people have already faced societal prejudice and discrimination on a day-to-day basis. The last thing they need is to go to a doctor's or a nurse or really a healthcare centre and face the same thing. But because of their experience of prejudice and discrimination, they may be very guarded about their gender and sexuality. We know that a lot of them would hide their sexuality and gender identity, but even if asked, they may still lie about it. And it is interesting to see that only 2/3 of male who have sex with males believe that their doctor is aware of their sexuality. That means that we still have a proportion of people who their doctor certainly, or they think that their doctor has no idea about their sexual activities. I think it's important to note our own sense of morality, prejudices, attitudes, and personal beliefs, which obviously is shaped by our own upbringing, maybe cultural and religious factors as well. But to provide good care for our patients, regardless of their creed and belief, we need to throw out any stereotypes that we might have. And there are certainly a lot of stereotypes out there, like the promiscuous gay man, or an angry lesbian, or the confused trans who's going to straighten up again, and things like that. So I think that those stereotypes are not always true, and they're more harmful than anything. And to also get into the mindset of not assuming that the patient in front of you is a cisgender heterosexual person, a straight person who's happy with their gender. Just never assume that for anyone. So that is very, very much within the heteronormative construct. So heteronormativity is a sociological term to refer to the automatic assumption that people are generally straight and people are happy with their gender, and that men would pair up with women and women would pair up with men, and then they all have children, everyone is happy. So I think that regardless of what your patient look, your patient might look like a cowboy farmer who wears a cowboy hat and it's dusty because it's just coming from the farm. Don't assume that that person is straight, and don't assume that person is cisgender either, because believe it or not, I actually have a patient who is male and is a farmer. So I should say was born as male and is a farmer and is married with a wife, but that person is transgender, but could not transition because that person felt that it would really destroy their family. So be curious, try to learn from your patients, and it's definitely okay to ask. We could also try to create a bit more of a safe space in the clinic as well. Certain things like posters, flags, badges, whatever video you're playing on the screen in the waiting area. These are really a quick visual aid to communicate to patients that they're welcome and it is a safe space. You know, the classic one is a rainbow flag, but it doesn't have to be a rainbow flag. It can be lots of different things. But it's also important to make sure that all staff members are comfortable or have had some sort of training in dealing with LGBTQI people. There's nothing more jarring than putting all these sort of posters and whatnot, which creates an illusion that it is a safe space. And then the staff members, when they're dealing with their patients, make the patients feel that they don't understand about being different in gender or something like that. So you need to have a congruent decoration and space, and also the staff members need to be also be a bit more sensitive as well. Think about registration forms or any other forms that you might have in the clinic, and make sure that it's not just sex, but also put gender as well in a field. Maybe even include a preferred name if it's not there as well. And another one that I think is helpful is to try to use the right gender pronouns, certainly in front of the patients, but even behind the patients when the patient is not there, because it will retrain your brain to use the right gender pronouns. When I was sort of at first fairly new to this, I was misgendering as well. But then after a while, it becomes second nature, and you don't misgender anymore. But it requires a bit of practice. So it's good to practice and train yourself wherever you can. There are some helpful phrases, perhaps, so that you can use. So usually what I say is that, you know, look, I know that looks can be misleading. Can you tell me what your gender is? Just simple as that, just direct, nothing, you know, don't beat around the bush. What's your pronoun? Do you have a preferred name? If you accidentally misgender, so someone who's a trans woman and you accidentally refer to that patient as a he, I would suggest just immediately apologizing. So that can happen while, for example, the patient's in your room and you're making a phone call to someone else about this patient, and then you would need to refer to the patient as he or she, and that's where you would likely to misgender. If you do, immediately apologize, and the patient will be very thankful for that. Be aware that some transgender people may not be publicly out yet, so they may still use their original name and pronouns in, say, for example, in the clinic room, waiting room. So use whatever pronoun that they prefer in the public spheres, and then in the privacy of your consulting rooms or treatment room, then you can switch to their preferred pronouns and names. There are some more gender neutral language that we can use as well. And generally speaking, if you're not sure, you might as well just use gender neutral language. So, rather than saying a penis or testicles or vagina or whatever it is, just say genitals, for example. Something that's a bit more open. But you can also listen to the patients. What words do they use? So, for example, if I say, we're talking about your genitals, and then the patient suddenly refers to their genital as vagina, then that may clue you in that you can perhaps use that same term that the patients use. But again, just check if you're not sure. So you might say something like, or you might ask, I noticed that you used the word vagina. Is it a word that we can use? So ask permission, and you'll be fine. Let's go through a little bit about some tips on taking a sexual history. When do you take it? Well, I think these are suggested situations or scenarios where you would want to take a sexual history. First of all, as part of a routine full medical history. So you're talking about past medical history, family history, medications, allergy, social history, yada, yada. But you can take a sexual history as well. And the benefit of this is that it signals to the patient that you're open to discussing about sexual health issues, which they might be more open, perhaps in the future. Obviously, if the patient comes in with a particular problem or symptoms that involve their genitals, such as pain or swelling or rash or whatever it is, then you need to take a sexual history. If there are non-specific febrile illnesses or flu-like illnesses, especially if there's no obvious context and in a return traveler, you might need to think about, is this a febrile illness associated with syphilis, or is it a HIV seroconversion? So you just need to think about that. If the patient requests STI testing, obviously you need to take a good sexual history as well. But some other opportunistic things that would be well suited would be when talking about contraception, when patient comes in for cervical screening tests, and also for preconception or antenatal consults. A travel medicine consult is also one where it is suggested to take a sexual history as well. Some tips. I think that patients will be more open to being truthful and honest in sexual history if you assure confidentiality and just really spell it out, because people are a bit apprehensive about talking about something so intimate. And tell them that you're here not to judge. Definitely throw out heteronormativity out of the window. Don't assume single people are promiscuous or married people are monogamous. People can do whatever they want. And remember that your person's gender identity has nothing to do with their sexual preferences. And try to use gender neutral questions when you can. And when you do ask questions about when you're taking sexual history, ask questions about sexual activities and behaviors rather than about sexual identity. So you ask them, do you have sex with men, women, both, or neither? Rather than, are you gay or homosexual? Because that can be quite confronting particularly, for example, in men who have sex with men who don't necessarily identify as being gay, but they do sleep with men on the side. Try to keep a poker face when you're taking history, and keep an open body language. Don't cross your arms. And the attitude is that you should expect a wild answer, so that when you do actually get a wild answer, you're not surprised. You don't look like really surprised, because patients will see that obvious body language. Let's go through some examples of how I might open up sexual history taking. So I might say, I'm going to ask some questions about sexual history, because, and particularly if patients come with symptoms, I might add, because it might be relevant to your symptoms. Is that okay? Or we might say, I'd like to ask you some questions about your sexual history so we can decide what test to do. And what we discuss here is confidential, and if it's okay, and it's okay if it includes partners outside your current relationship. I'm not here to judge at all. You could also say something like, your sex life is not for me to judge. I only want to make sure that you're safe and healthy. If your patient is transgender or gender diverse, then you might ask them, do you have any terms for your genitals that you'd prefer we use? Other opening statements would be if patient comes in for cervical screening or contraception, or they're here for travel medicine consultation, you can sort of use some of these sort of example statements as well. And then you get into the nitty-gritty of sexual history. So you need to just be direct. And I just, again, ask with a poker face, and I ask them like I'm asking them about whether or not they've had coffee yesterday. Did you have sex with men, women, both, or neither? And ask them about when's the last time you had sex. So this is important because you need to determine incubation period, test, window period for testing as well. Who have you had sex with in the last 3 months? If they said, no, it's just my partner. And then just follow up with, other than your regular partner, have you had sex with anyone else? So you need to be persistent. You need to be dogged in your questioning. You need to make sure that if you can, account for all their sex partners. Do you have oral sex, vaginal sex, or anal sex? If you're dealing with a gay man, or men who have sex with men, or a trans man who have sex with other men, then you ask, do you have oral sex, anal sex, or rimming? And do they say that, yep, I do have anal sex. With anal sex, do you top, do you bottom, or do you do a bit of both? I find that this line of questioning is a bit less confronting. And I don't really use the quite clinical term like, are you the receptive partner or insertive partner? It's just a bit jarring, I find. I think if you try to keep it casual or use casual terms, it's actually going to result in a better sexual history experience for both yourself and your patient. Ask them about condom use as well. And then ask about if they've ever been diagnosed with or thought they have had an STI. So some of the other things that you might try as an example question is that you can get STIs in your throat, bottom, or genitals. Do you think we should test any of these sites? Particularly if they're coming in for requesting an STI testing. You could also ask if you feel that based on your history that your patient might be in a high risk group. So you could say something like, people in these groups are at high risk of having a sexual transmitted infection. And they show you the lists on the right, rather than reading it out. Do you think any of these apply to you? Because then patients can just quietly read that, scan it, and then say, yes. That means that you need to apply additional STI testing or screening, for example. Which brings us to the testing itself. For gay men, bisexual men, men who have sex with men, or transgender people, the best practice recommendation is to test every 3 months. You want to do a full panel chlamydia, doing a first pass urine, a throat swab, anal swab, same with gonorrhea. Syphilis serology, HIV serology would be, those 4 would be the bare minimum every 3 months. And then additionally, you might do hepatitis A serology if the patient does rimming and has not been vaccinated. So you might want to do that. But if they've been overseas, so say for Thailand, and they've had their typhoid and hepatitis A vaccination, then you don't have to worry about that. Particularly if they had 2 doses of hepatitis A. Hepatitis B, if you might want to test that if you are not sure about the immunization status. Hepatitis C is suggested to be done annually. Particularly because hepatitis C is so easy to treat as well. For lesbian or women who have sex with women, chlamydia, gonorrhea, and syphilis serology. Syphilis serology is not something that you want to do all the time. You can do regularly as well, like some women might have it every 3 months. But again, it probably depends on where you're at as well. So if you practice in an area where there's a higher degree of, or higher rates of syphilis, you might want to do that every 3 months, for example. But otherwise, in low rates, you might do an annual test for syphilis. Let's talk about preventive sexual health. We are just about to finish that, in actual fact. Sorry, that's going to skip that bit. So cancer screening. For transgender people, it really depends on their remaining anatomy. If a trans women have started hormones, they transition from male to female, they're on hormones, they've developed breasts, then they're going to need to get breast cancer screening. And again, the timing is just the same as any other cisgender patients. Prostate cancer, for example, if they opted in, so a trans woman who was born as male would still have prostate, even if they have sexual reassignment surgery. So that needs to be screened as well if the patient opts in. Cervical cancer, the same as well. If the patient has cervix still, you need to screen for that. And you need to be sensitive about this because cancer screening can either be emotionally upsetting. So for example, if a trans man who still has cervix is really dysphoric about having female genitalia, and then you need to organize cervical cancer, it can be quite upsetting. So you might need to then think about, do we do a self-collection? But for others, it can be gender affirming. So a trans woman born as male has developed breasts as a result of hormone therapy. Having breast cancer screening is quite affirming. They feel like they're just like any other women. You need to think about HIV PrEP in high risk group, particularly in gay, bisexual, men who have sex with men. That's something to seriously consider. Certain immunizations, again, hepatitis A, meningococcal ACWY, again, depending on the time. Sometimes you might have some cases and the Department of Health might make recommendations and things like that. Again, HPV or Gardasil as well. Trans men who are on testosterone, so they're born as female and they transition to men into a male, they still need contraception because testosterone is not contraceptive. Those are some of the resources. And any questions?
Thanks so much, Haris. Definitely, there's a few questions I could ask, but I won't jump in just because it's everybody's Tuesday evening. Obviously, happy to hang around if anybody does have any questions and they'd like to speak up. But could folks, if something comes to them later, also send an email to us and we can pass it on with any other questions. If there's something that you might be able to help them with.
I hope that that was a good, or at least a reasonable sort of overview of things. It was quite a lot of things to cover in an hour, but yes, happy to accept any questions or discussion, or you can share your experiences as well if you like.
Well, folks are starting to leave, and I think I tend to, when I'm facilitating, go with a good 15-second rule. Speak up or forever hold your peace, I'm going to say, folks. I see lots of thank yous and lots of praise in the chat. Cool. Well, I think we'll call that an evening. Thank you again, Haris, so much. For those folks still here, if you want to revisit this session, it will be available on the Search YouTube channel. And thank you very much, Dr. Noor.
All right. Thank you very much, everyone, and thanks to Search as well for hosting.
Cheers. Thanks so much. Bye, everybody.
Bye now.